Welcome to this podcast on myocardial metabolism and myocardial preservation. My name is Dr. J. Thomas Murphy, and I am in the Department of Anesthesiology at the University of Kentucky. This podcast is being presented in August 2016 for the PGY3 CA2 first rotation residents. The resources for this podcast are found primarily in the 5th edition of Hensley, A Practical Approach to Cardiac Anesthesia. I suggest that you read the text references before watching this podcast. The educational objectives of this podcast are as follows. First, to be able to recall relevant cardiac histology and gross anatomy as relates to the topic. Second, to recall the normal metabolism of the heart, that is ATP production. Third, to explain the factors which affect myocardial oxygen supply and demand. Fourth, to recall the normal substrates for aerobic myocardial metabolism and anaerobic myocardial metabolism. Fifth, to explain the rationale of aortic cross-clamping and cardioplegia, and finally to discuss alternatives to aortic cross-clamping and anterograde cardioplegia. First, let's approach histology and anatomy. As you have most likely studied this in the past, this review will be incomplete, and if you are missing any details, I suggest that you at least review the first chapter of Hensley. However, the sarcomere is the functional unit of tension, shortening, contraction, ejection, and stroke volume in the heart. Several sarcomeres in series compose a myocyte. The sarcomere is composed of myosin, the tropomyosin actin troponin complex, and a Z disc. The active range of sarcomere length is between 1.9 and 2.2 micrometers, which is 15% of its length. You should review the length-tension relationship as shown in the first chapter. As you probably remember, sarcomeres contract with the calcium influx, which requires ATP, but most of the ATP consumption, up to 75%, is used for relaxation via the myosin ATPase enzyme. The capillaries which supply myocytes are 1 millimeter in length, so each capillary supplies multiple cardiac myocytes. The structure of capillaries and myocytes in the heart leads to local zones of ischemia and or infarction, which increase in volume as the occlusion becomes more proximal. The mitochondrion is the organelle in the myocyte where ATP is produced. It is stated in Hensley that the substrate for ATP and phosphocreatine production is readily available. This assumes normal blood flow and substrate availability, including oxygen and glucose. The heart prefers glucose but can use free fatty acids and lactate and ketones. The store of oxygen in the cell is myoglobin, and although the oxygen reserve is in the order of seconds, fuel in the form of carbohydrate and lipid quotes can fuel the heart for almost an hour. Most likely, in medical school, you learned that there was a difference between aerobic metabolism of glucose and anaerobic metabolism of glucose in the heart. Aerobic metabolism of glucose yields 36 moles of ATP per molecule of glucose, whereas anaerobic metabolism of glucose yields only 2 moles of ATP with accumulation of lactate and hydrogen ions. Myocardial lactate production, that is, the concentration of lactate in the coronary sinus effluent being significantly greater than the arterial inflow, is a sign of anaerobic metabolism. In the 1980s and early 1990s, much research was done examining the effect of anesthetic agents on myocardial metabolism. If the concentration of lactate leaving the heart is greater than the concentration entering the heart, this is likely to represent myocardial lactate production and ischemia. I can only show you how complex myocardial metabolism really is and hint at how inborn errors of metabolism and acquired metabolic disorders, including diabetes and obesity, can affect cardiac function. This slide is from Braunwald's textbook, The Heart, and shows some of the substrates for oxidative phosphorylation and reminds you why you studied Krebs cycle. Let's now talk about myocardial oxygen supply. Chapter 11 of Hensley's textbook, The Anesthetic Management of Myocardial Revascularization, covers this to some extent. Myocardial oxygen supply begins with the coronary arteries, which you must have studied in previous readings and lectures. The oxygen content of arterial blood to the heart is a function of hemoglobin concentration and saturation. And finally, the control of blood flow in coronary arteries is affected or defined by coronary vascular resistance. Coronary vascular resistance is mainly influenced by metabolic factors. You probably remember being taught that during ischemia, coronary arteries are maximally dilated, and that this is because of metabolic mediators. Nonetheless, there are opposing forces, and Table 11.2 summarizes them for you. One thing to consider when using potent vasoconstrictors is whether or not they could affect coronary vascular resistance enough to impair oxygen delivery. For example, can exogenous vasopressin be deleterious to coronary vascular resistance and coronary blood flow, even though it raises the perfusion pressure? It's for this reason that many cardiac surgeons are reluctant to hear that you're using a vasoconstrictor in the resuscitation of an ischemic heart. In the normal heart, unopened capillaries are recruited during times of increased demand. The coronary vascular resistance can also be affected by viscosity of the blood, and the colder the patient, the lower the coronary vascular resistance is with lower hematocrits. The coronary vascular resistance can also be affected by the distending pressure within the vessels and whether or not you are considering the subendocardial layer or the subepicardial layer of the heart muscle. Left ventricular subendocardial blood flow is mainly diastolic. However, the epicardial blood layers may receive some blood flow during systole. The coronary perfusion pressure equals arterial driving pressure minus back pressure to flow. This is expressed in the formula CPP equals aortic diastolic pressure minus LV-EDP, or left ventricular end diastolic pressure, because this is the pressure which compresses the endocardium during diastole and impedes blood flow to the cells. As well as diastole shortens relative to systole when the heart rate increases, some endocardial blood flow is decreased at rapid heart rates. Therefore, to summarize, if you want to optimize coronary perfusion pressure, typically you aim to achieve normal to high diastolic pressures, low left ventricular end diastolic pressures, and low heart rates. The left ventricular end diastolic pressure is equivalent to or is approximated by the left atrial pressure or the pulmonary artery diastolic pressure if there is no mitral obstruction. In stenotic coronary arteries, myocardial blood flow is affected by the length of the stenosis and the number of stenoses. Remember that a 50% reduction in diameter results in a flow reduction to 1/16 of the initial value through Poiseuille's law. There is more or less a fixed relationship between the number of capillaries and muscle cells. So with hypertrophy of muscle cells, the increased distance for blood to travel and for oxygen to diffuse, and the increased ATP requirement is not met as well. Carrying on with myocardial oxygen demand, it is notable that doubling of the heart rate more than doubles the oxygen consumption because of a concurrent increase in contractility with heart rate increase. Contractility affects oxygen demand by virtue of greater oxidative metabolism and in limitation of blood flow to the subendocardium. Wall stress is a function of afterload, preload, and wall thickness. Of these three, heart rate and contractility are more within our control, although chamber size and chamber pressure can be influenced by venodilation. In the worst case scenario, tachycardia and increased LV-EDP lead to increased demand and decreased supply of oxygen. Well, this is the last slide of the podcast, and I thank you for listening and for using your textbook in this review of myocardial metabolism and intraoperative myocardial protection.